Good afternoon. I want to thank the management of Arnodia Charitable Trust for giving me this opportunity to share some of my thoughts relating to incorporating eye care in healthcare, which I feel is a necessity going forward. So if you look at the eye care conditions and dependencies, uh, things like cataract, refractive errors, and glaucoma are predominantly, I would say, less dependent on any other field of medicine. They're predominantly ophthalmology dependent. And all of us in real life recognize that. And then these happen to be most of eye care. But then today we are into dealing with multiple other conditions, like diabetic retinopathy, wherein that works really well if you have a strong relationship or work with general medicine, endocrinologists, and so on. Similarly, for effective work in retinopathy of prematurity, both for intervention and prevention, we need to work very closely with the neonatologists. And similarly, for pediatric ophthalmology, it works much better when pediatricians are involved, and they are supportive of this. Similarly, for neuro-ophthalmology, we need to work with neurologists and neurosurgeons. And the list goes on. For trauma, depending upon the site and things like that, it becomes a multidisciplinary work. And for some of the plastic work like DCR and all that, we need to work with the ENT specialists. So the dependency is kind of increasing as the scope of eye care increases. So when it comes to case finding and referral, which is very fundamental for providing eye care, so the timely case finding is a proactive process. In the hospital, we tend to be reactive by treating those who come to us. But if we really want early intervention, then the process has got to be proactive. And this happens best at the community level, not at the hospital level. So when we look at general health care, they are much better organized for this, through the different tiered levels of care and staffing and so on. So that's, again, an important part or a necessity for this integration. Again, the character of eye care is changing from one-time intervention or episodic care, like doing cataract surgery or prescribing glasses, to chronic care. This is now getting added on for conditions like diabetic retinopathy or glaucoma and so on, macular degeneration, the list kind of goes on. So this really requires constant good compliance to treatment and regular follow-up. And this again, for this to happen, the action is at the grassroots and community level. So community health workers like ASHA, they are best placed to do this and to support this chronic care management. So that's another reason. In conclusion, the message that's emerging clearly is that the character and the scope of ophthalmology is changing. It is now including eye conditions caused by lifestyle, like diabetes or hypertension. The dependency on other health disciplines is increasing. And then in terms of the caregiving process, it is becoming more and more chronic care management. So all of this is pointing to the necessity that we need to aggressively explore ways to integrate eye care with general health care, to facilitate both early case referrals and to support chronic care management. So this integration is really about creating synergy, both for ophthalmology or eye care and for the other disciplines that we work with. Thank you.